Okay, so the webinar has started. Just checking with you, Tandega, have you let anyone in? Okay, I can see people are flowing in. Okay. Dr. Lynn, can we just give it like another 5 minutes and then we're gonna start? I can see that people are coming in, but I'm just gonna give it a 5 minutes and then we're gonna start.
Yep, sounds good. Happy to do that.
Thank you.
I can. Do you want me to share the screen now, or
Of course you can. If you feel more comfortable sharing it, yeah,
Yep.
you can.
Yep, I'll just share the screen.
Okay, it seems like we have a significant number of attendees. I'm just gonna start the webinar now because South Africa and the rest of Africa is in their lunch hour. Some are in the lunch hour, some are still in the morning, just settling in at work. So I'm just going to start for the sake of time. And yeah, thank you again, Dr. Lynn, for sacrificing your evening just to come and share your insight with us. I'm just going to read your bio. Dr. Ong is a multifaceted mid-career academic who balances extensive teaching and administrative responsibility while leading a productive research group. His research is focused on the pathophysiology of stroke, of post-stroke secondary neurodegeneration and cognitive impairment, the role of stress biomarkers, and the development of therapeutic, and the development of therapeutic strategies for brain recovery. Dr. Ong's research career is on an upward trajectory, having published 58 peer-reviewed articles, 2 book chapters, and 2 editorials, as well as over 25 invitations to present his work at conferences, institutions, research workshops or schools, and community presentations. He has published pioneering research on post-stroke secondary neurodegeneration and cognitive deficit in, sorry, where did I lose myself? He has published pioneering research on post-stroke secondary neurodegeneration and cognitive deficit in leading stroke and neuroscience journal, including Brain Stroke, Journal of Cerebral Blood Flow and Metabolism, GLIA, and Journal of Neurochemistry. His pioneering work has demonstrated persistent brain atrophy, neuroinflammation, and neurotoxic protein deposition and cerebrovascular dysregulation in brain regions remote from the initial infarct. These findings are accelerating the development of targeted neuroscience-informed treatments for stroke. His research has also provided critical evidence linked elevated stress levels to poorer stroke outcomes. Currently, he is building the evidence base of stress reduction interventions, including deep breathing and mindfulness to enhance individual well-being. His work bridges fundamental neuroscience and translational outcomes, contributing meaningfully to both academic knowledge and clinical practices. Beyond research, he serves as a medical sciences discipline lead with overseeing a team of 14 direct reports, and is also the program director of biomedical sciences. Each year, he teaches over 800 students per year across diverse programs, including medical science, medicine, paramedicine, and nursing. His leadership roles include appointments to emerging leaders group of International Stroke Recovery and Rehabilitation Alliance, Young Sciences Network Academy of Sciences Malaysia, editorial board, fellows of neuroscience, and past IBRO early career committee. Thank you very much, Dr. Ong, again for joining us. We are very privileged and very grateful that a man of your stature would take his time and spend it with us during this lunch hour, sharing his insight. I'm going to mute myself now and remove the video, and I'm going to give you the platform to share. And then after that, I'm going to allow the audience to either text questions or to switch on their microphones and ask any questions. Thank you.
Thank you for such a kind introduction, and thank you everyone for coming and listening to my talk. So for today, I will be focusing my talk on post-stroke cognitive impairment and dementia. We will dive into the mechanistic insight, and we will explore some of the therapeutic strategy for secondary neurodegeneration. So this is a quick overview of the outline of today's presentation. I'll give you a quick background of post-stroke cognitive impairment and dementia. We'll discuss a little bit on the pathophysiology, focusing on secondary neurodegeneration. And I will share some of the findings from preclinical studies that I've undertaken along with many collaborators over the past years. So when we talk about stroke, I think this is a very important image. Hopefully, many of you have seen this before, and hopefully you're aware of this. So pretty much here you can see BFAST, which is a mnemonic for recognizing stroke symptom. So B for balance, which is a sudden loss of balance. E for eye, which could consist of vision's problem. F for face, so one side of the face dropping. A for arms, weakness in one arms. Speech, S for speech, slurred speech. So if someone is present with all these symptoms, you should be calling emergency service immediately. So T is time. In the context of stroke, time is brain. So recognizing this sign and acting quickly is crucial, as every minute matters for effective stroke treatments. Now that you know the symptoms, I'll just quickly talk about, so stroke is a medical condition in which interruption of blood flow to the brain causing cell damage or death. And here you can see two types of stroke. So stroke can be classified into ischemic stroke, which is mainly caused by a blockage of blood vessels. So here you can see a blockage, or a hemorrhagic stroke, which is caused by a rupture in a blood vessel. So here you can see a rupture in the blood vessel. And stroke is a massive burden to not just Australia or Africa, but actually globally, with about 1 in 5 people suffering from stroke in their lifetime. and over 12.2 million new stroke each year. So here you can see a very nice figure by the Lancet Neurology, indicating that there's billions of individuals have affecting condition related to the nervous system. And up here you can see stroke is the leading neurological condition. And having said that, over the recent year, there's great improvements in acute stroke treatments. So treatments such as mechanical thrombectomy and tissue plasminogen activator have rescued and saved many people from dying from stroke. And the number of people dying from stroke has significantly reduced. Having said that, that means globally, the number of people living with the effects of stroke has now shifted to markedly increase. So there are more and more people surviving or living with the effects of stroke. And currently, there are over 100 million people living with some degree of post-stroke complication. And I would also want to take your attention to dementia as well. So dementia, it's the fourth leading neurological condition related to the global burden as well. So in the context of a stroke, while impairment of the motor function is common, and it's typically the central focus in stroke rehabilitation, we should note that stroke also affects cognition. So post-stroke cognitive impairment is common. It can persist for years. And in the context of stroke-induced dysfunction, it can cause dysfunction in various cognitive domains. So this include domains like cognitive flexibility, attention, working memory, spatial memory, and all these impairment or the cognitive impairment are known to significantly worsen the quality of life of the stroke survivor. And if you can see this wonderful meta-analysis where it consists of 9 different studies from 7 countries as part of the Stroke and Cognition Consortium. When stroke patient it's compared to controls, here you can see stroke patient experience significant cognitive decline faster than a stroke-free control. So here you can see the non-stroke individual, when it compares to stroke, there's a significant decline. And there's a huge increased rate of decline when there's a reoccurrent stroke. So, so the green bar over here, it's a stroke, a single stroke, and the yellow bar over here, it's multiple stroke. So having multiple stroke could significantly increase the rate of cognitive decline. And when we talk about post-stroke cognitive impairment, about a third of individuals with stroke go on and develop dementia within 5 years. So certainly stroke is a risk factor for dementia. So here you can see a study, a UK study, a prospective cohort study of 43 stroke survivor, and they look at the cognitive impairment versus the stroke impact skills. And here you can see there is a clear trend showing poorer or poorer stroke cognitive performance or having higher cognitive impairment significantly worsen post-stroke outcomes. And when it looks at different post-stroke outcomes, such as memory, emotion, communication, everyday living, participation, once again, there's clearly a trend showing cognitive impairment negatively impact the post-stroke outcome. So one of the work that I've carried out back in 2020 in Newcastle, the Hunter region, we look at stroke survivor in the chronic phase, and we wanted to look at the correlation or the association between specific cognitive domain to the stroke outcomes. So that's me administrating a iPad-based cognitive assessment. So this is Cambridge Neuropsychological Test Automated Battery, CANTAB, which can test domain-specific cognitive assessment. So we look at various things like reaction time, pair-associated learning, and spatial working memory. Here you can see a quick demographic. So we look at 70 stroke survivor and 70 non-stroke age match control participants. So in terms of when we look at various cognitive tasks, when we look at a reaction time, which look at the attention, visual spatial pair associated learning, which look at learning and memory, and the spatial working memory, which is an executive function, there is a clear significance of showing stroke survivor had poorer cognitive performance compared to the control cohort in all these different cognitive domain. We then go on and look at this specific cognitive domain and the association with the stroke impact. And here you can see cognitive domains such as attention. So having a poorer attention is associated with multiple stroke impact outcomes such as strength, memory, communication, activity of daily life, hand function, as well as social participation. Whereas when we look at learning and memory, it has impact in only memory, communication, and social participation. And when we look at spatial or executive function, there's association with communication. So this finding highlights there's a clear interplay between a variety of domain-specific cognitive impairment and dimension-specific functional outcomes. So therefore, I think based on this, we do need to look at focus on, in addition to global cognition, we should also look at specific cognitive domains. So I think I'll move forward to the next part of the talk. And the next part is to focus on the mechanism that's related to, or mechanism related to post-stroke cognitive impairment or vascular dementia. Here you can see a very nice image by Diglins and Lace in circulation research. Basically in this image, it shows that there are multiple etiologies of stroke, and this can lead to vascular cognitive impairment. However, when we look at the neuropathological characteristic, typically there are two major settings. So the first setting is the vascular causes. So when we talk about vascular causes, it could be cerebral small vessel disease, cerebral amyloid angiopathy. It could be large artery occlusions. It could be hypoperfusion. So this would be vascular nature. And then the second one, it's related to brain parenchyma lesions. So things like strategic infarct or multiple infarct, deep hemorrhage, microbleeds. And I think why I'm for the interest of this talk, I want to primarily focus on secondary loss of white and gray matter, which is brain atrophy. So, what is secondary neurodegeneration after stroke? So basically, post-stroke secondary neurodegeneration, it's a progressive loss of brain tissue at remote brain region that's connected to the initial infarct site. So these include areas such as the thalamus, basal ganglia, white matter tract, and hippocampus. And this secondary neurodegeneration, it's observed between 1 month after stroke and can persist for many years. So this is a very nice image, MRI image, and a representative of secondary neurodegeneration after stroke. So here you can see a typical ischemic stroke in the left MCA territory. So here you can see the infarction site. When the right hippocampus being blown up, when it's observed over a 12-month period, there's no clear significant changes in the tissue volume or the hippocampal volume. But if we're looking at the ipsilateral, which is the left side, the hippocampus, if you can see over here, I just get your attention. So at 1 month, there's already a marked reduction. And when we look at 3 or 12 months, there's even a significant reduction in the tissue. So there's a tissue atrophy happening. And you can also see there's more space in the brain from there as well. And many other studies, some from Australia and others, they have shown that this brain atrophy, it's related to post-stroke cognitive impairment. So I've shared quite a fair bit of information or clinical related findings or information. And part of my work, we are particularly interested in finding the mechanism, and therefore we've got this bedside to bench approach or clinical to lab approach. So we model what is seen clinically, and we also want to see if we what are some of the targets that drive this remote brain atrophy, and can we target this, right? So the stroke model that we use extensively is the photothrombotic stroke model. So the photothrombotic stroke model, basically, it's where mice are injected with a photosensitive dye called rose bengal, and we expose the skull. When we use a light source, when the light source react with this photosensitive dye, it will cause platelet activation and then thrombosis, therefore leading to a stroke. The advantage of this technique is we could shine the light at regions of our interest. And in this particular model, we focus on the left motor and somatosensory cortex. And here you can see a TTC or triphenyl tetrazium chloride staining showing the infarction site. So we can vary with this model, we can actually control where we want to induce this stroke. And using this model, we then go on and investigate long-term impact, particularly cognitive outcomes, and also look at all the various neuropathological changes. So when we look at the functional outcome, we do focus on the cognitive functions. So with the cognitive behavioral assessment, we're fortunate enough to be able to use the touchscreen based cognitive assessment. So the first one that show you is a visual discrimination reversal task. So visual discrimination reversal task is when we first train the animal to identify fan as the positive stimuli and marble as a negative stimuli, and allowed the animal to learn. And once the animal can perform to the extent, we then go on and reverse the symbol to look for whether there's the cognitive flexibility. And the finding, it's very interesting. So the blue graph, it's non-stroke animal, and the red graph, it's stroke animal. In terms of acquisition, both stroke and non-stroke animal do learn the stimulus, but during the subacute phase, when we swap or reverse the symbol, stroke animals has poorer performance, and this occurs during the subacute phase, so in between 7 to 8 days post-stroke, as well as all the way to chronic phase, which is 2 months to 3 months post-stroke. So this is done by Sonia Benzanilla, which is a past PhD student. She's graduated already. We also look at the pair associate task. I'm not going to go into too details about the task, but here you can see that during the subacute phase, once again, the stroke animal perform poorer compared to the non-stroke animal, and this remain persistent all the way to chronic stress. And in terms of why do we want to use this touchscreen based assay, we did a comparison between the stroke model or preclinical stroke model and stroke survivor. And when we look at this pair associate learning task, both we can see that the mice that's 6 months post-stroke perform far poorer compared to the non-stroke animal. And when we look at the stroke survivor in human, we also see the similar trend. So this provide a very exciting approach for translational study. Particularly, we can use something similar in preclinical as well as in human. We then go on and in the animal model, we then go on and extract the brain and look at various aspects of the brain. The first part is we look at the whether there's any neuronal loss. Um, in terms of we look at various regions. So when we look at the CA1 in the hippocampus, so here you can see the yellow staining, which is new N staining. It's a marker for mature neuronal marker. And when we look at this new N staining at CA1, there's a marked reduction at 1 month post-stroke, and this further reduced at 3 months post-stroke, or 84 days post-stroke. We also look at neuroinflammation, and in this case, here you can see IBA staining, which we stain for microglia. And in this model, at 7 days post-stroke, we do see a marked increase in the IBA positive cells. And just looking at the temporal changes, we do interpret this as the microglia activation precede the neuronal loss, suggesting that neuroinflammation may be playing a very important role in the secondary neurodegeneration. In terms of microglia activation, we also have many sophisticated way of analyzing the microglia cells. So in addition to measuring the cell number, we can also look at things like soma size, cell area, primary branches, and so on and so forth, because we do know that microglia morphology do provide a good indication of the phenotypes. So here you can sort of see an example of the analysis: cell number, soma size, cell area, cell radius, and so on and so forth. And basically just quick take-home message is there is a persistent increase in IBA1 positive cell number, and suggesting that all these microglia as well are very reactive, in a reactive and active state. In addition to microglia, we also look at amyloid beta. Here you can see amyloid beta as it moved towards from sham to 3 months post-stroke. There's a clear and marked increase of the A beta aggregation, so oligomerization, so suggesting that microglia go from monomeric form to dimer, and so on and so forth. And stroke do cause that altered oligomerization. When we look at histology or immunohistochemistry, there is a clear increase in amyloid beta accumulation in the brain. So that sham, it's very dark. You can't see any amyloid beta staining. And following stroke, there's clear increase in amyloid beta staining. When we look at colocalization of the amyloid beta with the vasculature, so lectin is used to stain the microvasculature. We can see initially amyloid beta, it's scattered in the parenchyma of the brain, and towards 84 days or 3 months post-stroke, amyloid beta start to localize around vasculature, suggesting there might be some form of cerebral amyloid angiopathy occurring. So that finding do then encourage us to explore further, and so we then go on and look at cerebral vasculature changes in our model, and our finding as well do appear in the journal album up for the Journal of Neurochemistry. Basically, when we look at cerebral vasculature, so all those small vessels within the brain, following stroke, there is actually there is a marked change in cerebral vascular morphology. So there's changes in vessel coverage, there's changes in vessel length, there's also changes in the vasculature branches. So following stroke, we actually see there are more microvasculature coverage. All those vessel length are longer compared to sham, and increased number of vasculature branch. So that sort of suggests that there is some form of brain regeneration occurring. So there could be an angiogenesis and or vascular genesis happening after stroke. But the problem with having while the coverage and there are more vessel, it's quite important to know that whether these vessels are functional. And we go on and see the average vessel diameter, what's striking is at 3 months post-stroke, all these vessel diameters, they are significantly smaller. And when we look at co-localization with amyloid beta, having amyloid beta surrounding the vessel diameter, it's significantly smaller compared to non-amyloid beta deposit. So this is particularly important because all these small brain blood vessel could have a very significant impact on the brain function. So all the works that I've shown so far, it's conducted using the mouse photothrombotic model. Over the recent year, I'm quite fortunate enough to work collaboratively with Associate Professor Renee Turner and also Dr. Rebecca Hood. They are both based at University of Adelaide. And as part of the translational research interest, we did move from the mouse model to rat model all the way to sheep model as well. So looking at sheep allows us to look at brain scan, look at brain blood-brain barrier permeability. So that's a sheep in an MRI, and we do have more samples to work with as well. So yeah, do stay tuned for findings and results from this ovine or sheep stroke model. So I think I'm going to try to wrap up for the interest of time. So so these are work done over the last 8 or 9 years. Try to summarize all of them in one slide. So what do we know about post-stroke secondary neurodegeneration. And all these are preclinical finding summarized in a picture. But so basically, we do know that at sites of secondary neurodegeneration after stroke, there's a clear neuronal loss as well as synaptic dysfunction. There are marked increase in neuroinflammation. So in terms of neuroinflammation, there's clear microglia activation or as well as astrocytes activation. The peripheral immune cells do also infiltrate into the brain parenchyma. So all these contributing to neuroinflammation. There's clear evidence of accumulation of neurotoxic protein, such as amyloid beta, alpha-synuclein, and tau hyperphosphorylation, suggesting that there might be some dysfunction of the brain clearance system as well. And in terms of cerebral vascular, we do see there's clear dysregulation in terms of reduced diameter of cerebral vessels, reduce of pericyte coverage, and also marked increase of the blood-brain barrier leakage. So yeah, all these are in based on our preclinical findings. If you're interested to know more, I've published multiple review on this space in the last few years as well. So yeah, there are some reference that you could have a quick look. So that's a quick summary that I have covered. So stroke can cause long-term cognitive impairment and increased risk of dementia. Brain atrophy is among the strongest predictor of cognitive impairment in stroke survivors. I've outlined quite a fair bit of post-stroke secondary neurodegeneration pathophysiology, and there are many overlapping hallmarks to dementia. So in terms of, I don't want to end this research in gloom. There is quite a lot of opportunities with stroke recovery. So there's a book chapter that I've published recently to look at various regenerative therapies in ischemic stroke. And in this particular book chapter, we do look at the opportunity in terms of targeting adult neurogenesis. Here you can see our brain capacity to continue growing new cells. There are two major zones. So we've got the subventricular zone and also the subgranular zone, which has lots of evidence showing that there's capacity to continue generating new brain cells. And we do acknowledge that while the brain has the capacity to produce neuroprogenitor cells after stroke, there's only a very small or little percentage of these cells go on and differentiate and become functional in the mature neuron format. Because there are multiple factors that limited this process, and I have already outlined quite a fair bit of the processes in the secondary neurodegeneration space. So things like high inflammatory response, increase in oxidative stress, and actually there's very low neurotrophic support following stroke. Therefore, that do reduce the survival of neuronal precursor cells, reduce the neurogenesis process, and sometimes it may cause aberrant neurogenesis. So the neurons are not quite functioning the way we would want them to function. But obviously, there are several therapeutic strategies in this space that we could potentially enhance our brain capacity to regenerate. So we could try to stop this neuroinflammation with anti-inflammatory agent. We could promote the environment or promote that neurotrophic environment by providing endogenous trophic factors, things like growth factors, growth hormone, and also emerging techniques such as stem cell based therapies as well. There's a very great opportunity in that space. So further, in terms of therapeutic opportunity, I believe the secondary neurodegeneration or sites of secondary neurodegeneration after stroke is a very attractive opportunity. First of all, it has a extended therapeutic window, so it happened as early as 1 week to 1 month post-stroke, but there's a very extended therapeutic window. So it happened years after stroke as well. And a few approach, one is to enhance the brain plasticity, potentially using anti-inflammatory drugs to dampen this neuroinflammatory response, promote waste clearance, so trying to get rid of those neurotoxic protein. And so there are multiple emerging approaches from other neurodegenerative disease such as Alzheimer and Parkinson, where there are approach where we could potentially get rid of this neurotoxic protein, and finally promote this vascular repair and regeneration. So like after stroke, if there's no treatment, there's definitely increase in glia scar formation, vascular leakage because of the inflammatory environment. There's very limited plasticity and a lot. So the angiogenesis process sometimes it's aberrant as well. But if we could then go on and try to use some of these therapeutic opportunities such as cell therapies or so on and so forth, there might be a great opportunity to promote things like angiogenesis, promote vascular maturation, synaptogenesis, and immune modulation, so dampen the neuroinflammatory situation. So I think it's, I would say all the work that I've presented, it's not my work alone. So there's students involved and collaborators from around Australia and around the world as well. And also I need to also thank the funding for funding support. I also want to take this opportunity, if there's any potential student who is listening to the webinar. Currently, my university, University of Southern Queensland, has international stipend and free fee research scholarship opening at the moment. you can scan the QR code for more information, and the closing date is end of this month. So if there's any potential student out there who is listening and interested in the research or the research field that I'm in, feel free to reach out. So thank you everyone for listening, and I do want to leave some time for question and answer. So thanks everyone for listening, and I'm happy to take any question.
Thank you very much, Dr. Ong. That was a very interesting presentation you just gave us, and thank you for the level of detail and explanation. I really understood it. I'm not an expert in stroke research, but I really understood it, and it made me feel as if I can also do some research on this topic. Thank you very much. I had a question, and I mean, I think as I had the question, as you were sharing about the inflammation, the cognition, as well as the beta amyloid plaques that actually accumulate, I was wondering that would actually just targeting inflammation be one of the best interventions for stroke and maybe even Alzheimer's disease? But I know that you are not working on Alzheimer's disease, but I just wondered that would it be one of the most powerful ways to actually target an absolute or semi-absolute treatment?
Yep. That is a very wonderful, important question. I would say in the context of stroke, the neuroinflammation aspect, it has a temporal profile. In terms of targeting neuroinflammation, during the early phase, we do believe that inflammatory responses are critical for the recovery process, and we do believe that the late stage, the chronic inflammation, is detrimental. In terms of just targeting neuroinflammation, it may have some protective effects. But having said that, I've shown that following a stroke, the pathophysiology is not one mechanism per se, and I think a multimodal approach would be a more effective approach. So perhaps a cocktail of anti-inflammatory and growth factors, or certain approach that can target multiple cells. So certain targets that could perhaps dampen the inflammatory as well as promote the regeneration process.
Okay.
Yep.
Okay, thank you. Thank you. I don't know if there's anyone else with a question. Any other question from the audience? I don't see any questions, but I see a lot of thank you, Dr. Lin, great work. Thank you for the nice presentation. If there's nobody else asking a question, I'll ask one more question. But this is based on just your introduction, just the introduction that I read of your profile. Yep. You mentioned mindfulness as one of the interventions, and I also saw that there's also exercise in some of the interventions that you mentioned. Would you care to maybe mention briefly how would using mindfulness practices be effective in the process of healing? And of the practices of mindfulness, which one would you say is potentially the best to use?
Yep. that's again a very excellent question. So in today's presentation, I primarily focus on stroke recovery and cognitive impairment and dementia. My other line of research is in stress biology and stress management. And we do know stress is or chronic stress is a huge factors in many aspects in terms of brain function and so on and so forth. The ability to manage stress is very important, and as you mentioned, mindfulness is one approach, um, and yeah, in the context of stroke recovery as well, many stroke survivor report high amount of stress. So the ability to manage stress during recovery process is particularly important. In terms of what is the most effective mindfulness approach, well, over the last recent year, I have been building neuroscience or evidence-based approach in this lifestyle lifestyle changes management or stress management approach, and I I believe there there may not be one size fit all. So certain approach may be more effective for certain individuals, and other approach may be more effective for other individuals. So I think yeah, if we want to go on and say like yeah, this mindfulness technique will be useful or could be used as management process. I think it needs to have some level of personalization to help that brain recovery process.
Thank you.
Hopefully I answer your
You did.
yeah,
You did.
question.
Thank you,
Yeah.
Dr. Ang. We have a question here from Philip or Philippe,
Yep.
and they said, how's tau pathology involved in post-stroke disorders and eventually recovery? I'm also going to just hand over to Dr. Gladys Ngopai, because I have to have a hard stop, but she's going to take over with the questions and just to thank you and then close the meeting. So yeah,
Yep.
is the question, and then I'm just going to hand over to Dr. Ngopai. Thank you,
Yep.
Dr. Thank you so much,
Sure.
Dr. Ong. And thank
Thanks.
you, everyone.
Yep. Felipe, that's a interesting question. And over the recent year, we do start to dive into tau pathology. So in terms of tau pathology, in the aspect of post-stroke secondary neurodegeneration, we do see increase of tau hyperphosphorylation at sites of secondary neurodegeneration. So that could be due to abnormal activation of various protein kinases leading to abnormal or tau hyperphosphorylation. In terms of the second part of your question, when we talk about recovery, in terms of recovery, I'm not so clear. Yeah, perhaps tau could be a potential target for recovery. And at the same time, there's emerging biomarkers or fluid biomarkers using tau or tau phosphorylation as a potential biomarker. So that could be a potential use for stroke recovery as well. Hopefully I answer your question, Felipe. If not, yeah, feel free to send me email to follow up as well.
Thank you, Dr. Lin, for your answers. There's a question. People would like to know whether they can have your presentation.
Is this recorded? Is this presentation recorded?
I think
Yes,
so.
this presentation is recorded and will be uploaded onto our Sona website for people to view and watch.
Yep. So I think in that case, yeah. So feel free to go to Sona's website to view the presentation.
Okay. Thank you, Dr. Lin. I think Philip said that you answered right his questions. For now, there's no more questions. I would like to first apologize for joining late. I think I had an issue with the time zone. So thank you, Dr. Lin, for this brilliant presentation. And it was such an honor for us, for you to accept to be our guest speaker. Since there are no more questions, I think we are going to end up the presentation. And I think for all the attendees, you can contact Dr. Lin through his email because it's still displayed on the slide, or follow Dr. Lin on Twitter and also LinkedIn. And feel free to write to him. I think he's open to answer to all other questions that may come to your mind, because we have time limits. We may not maybe cover all the aspects. Thank you so much, Dr. Lin, for joining us.
Yep. Thanks, Dr. Gladys, for your kind invitation. It's a great honor to share my work with all of the attendees. For those who are interested with the stroke model or the techniques or the work, yeah, do feel free to contact me. And I'm very passionate in terms of training and upskilling early career researcher as well. So if there's potential, say, school or school support, yeah, I'm more than happy to support using my expertise as well. So do reach out to me, and if I have the capacity, I would definitely would love to support.
Thank you so much, Dr. Lin. I think if there are no more questions, then no, we are going to thank you again, Dr. Lin, for joining this webinar. Okay, we are going to close now.
Okay, thanks everyone.
Thank you, everybody. Bye.
Bye.